Hello guys, in this video we are going to see about the complication of otitis media, and first we are going to see about the acute otitis media. As we seen earlier, the acute otitis media most commonly causes the tympanic membrane perforation. Next to it is the acute mastocytitis, then collagen mastocytitis. These are the complications of acute otitis media, but the chronic separated media is the very important part. The most common complication of the CSOM is the ossicular chain erosion. Okay, then which can cause us conductive hearing loss. Then this can be complications can be divided into two types as intracranial and extracranial. In extracranial, it can be further divided into intratemporal and extratemporal. First, let's see about the intratemporal complications of the extracranial. Within the temporal bone, it causes ossicular chain erosion. This ossicular chain erosion plus tympanic membrane may cause a total loss of 45 dB loss. But when you correct it, if you correct only the tympanic membrane perforation and not repair the ossicular chain erosion, this when you close the tympanic membrane, further the sound reaching the stapes will be reduced, and it can cause a total loss of 54 dB loss. So you need to correct both the tympanic membrane perforation and ossicular discontinuity. It's very must. Normally, when if both the tympanic membrane and also discontinuity is lost, some sound may reach the inner ear. So it can lose only 45 dB loss. Then other complications like facial nerve palsy, then labyrinthitis, which may be serous or suppurative. The serous labyrinthitis is due to the fluid from the due to the toxins produced by the bacteria. Suppurative is caused by the bacteria itself. Both causes sensorineural hearing loss. Normally labyrinthitis is not occurring, but it's a complication. So the treatment for the labyrinthitis will be labyrinthitis drugs for the pain and IV antibiotics to treat the infection. Then the complication may be a labyrinthine fistula. Most common site is the dome of lateral semicircular canal on the medial wall of the inner middle ear. To identify this labyrinthine fistula, we need to do a fistula test by pressing the tragus. There will be a pressure change in the ESC. The pressure goes into fistula if present, which may produce a vertigo or nystagmus. We can apply our anesthesia with the Segal speculum. We can do this tragus pressure test. The two fistula test indicates that means vertigo nystagmus indicates the labyrinthine fistula. False negative fistula test is a seen in dead ear or cholesterol covering fistula. Whatever you do for urine pressure, if there is nothing dead ear, means we can feel the vertigo nystagmus. Then false positive may be seen in conditions like congenital syphilis and Meniere's disease. This is known as Henneberg sign. It's also in hypermobile stapes. That will be false positive. Okay. Then the next intratemporal complication is the petrositis. As you all know, the temporal bone contains many processes like petrosal process, styloid process, mastoid process, zygomatic process. So it is this petrositis is the inflammation of the petrous bone. It is there may be long-standing discharge, deep-seated or retroactive pain, diplopia of lateral. So there is a triad known as Gordon-Ego syndrome, which contains of 3D discharge, retroorbital, deep-seated retroorbital, and diplopia. And this occurs in a Dorello canal, which is a canal for abduction nerve. This due to this got inflamed the nerve and nerve the nerve to the eye. It is retroorbital pain and lateral rectus palsy will be there. It's a very important triad Gordon-Ego syndrome. Then let's come to the extratemporal complications. There is abscess formation is the extratemporal complication. You can see what is the post-oral subperiosteal. I marked in green, which is the post-oral behind the EAC. Post-oral, this is the post-oral abscess. Then the basalt abscess, which is present over the sternocleidomastoid. This is the mastoid process where the sternocleidomastoid muscle is from the sternum to the mastoid. Here is the abscess, so this is the dissolved abscess. And then Luke's abscess is present in the posterior superior wall of EAC. You can see here along the EAC posterior superior wall, marked in blue. Then the zygomatic abscess developed in the zygomatic arch, zygomatic bone. You can see here pink. And then the Centrally abscess, which may develop anterior to the mastoid along the posterior belly of digastric. Here in the green muscle is the digastric, along the posterior digastric, or posterior to mastoid it can develop. That is the Centralis abscess. You can see the pictures here: posterior abscess, basal abscess, that is the sternocleidomastoid. You can see here also basal abscess. Then the Luke's abscess along the posterior superior wall of EAC. In the Centralis abscess, that is along the posterior digastric or zygomatic abscess. In the, you can see here zygomatic bone. Then let's come into the intracranial complications, like meningitis is the most common. Then extradural abscess, subdural abscess, brain, that is 3 layers, meninges, pyometer and arachnoid matter. So like that, brain, subdural, extradural, and meningitis will be there. Then otic hydrocephalus, then sigmoid lateral sinus thrombosis. Among this, the lateral sinus thrombosis is a very important one, where the clinical features like pallor, headache, and picket pens fever, which is a very important note. The fever never returns to the normal baseline. This is things is the normal baseline. The fever common like a fluctuating like this, so this is known as picket fence fever. This is a remittent fever. The brain abscess is the inside pyometer, subdural is in below dura, extradural is the between skull and dura. Okay, then in this sigmoid lateral sinus thrombosis, there will be Graysner sign positive. That is the with the help of the emissary vein, this infection is transferred to the intracranial parts, sinus. Then the management, first is the Tobey-Ayer or Quiescent test. It is the compression over IVG on the normal side increases. Management first involves the investigation part. So when you compressing the IVG on normal side, this increases the CSF pressure in lateral sinus thrombosis. Okay, then there is a this is an invasive test. First you need to do a lumbar puncture to measure the pressure. When you compress the side IVG on one side, you can see whether the obstruction is there or not. Then Krobeck test, that is a compression on IVG on same side leads to engorgement of retinal veins. You can see the eye compression will causes the engorgement of retinal veins. And then MRI can show the you can see the empty delta sign here. Is a confirmatory for lateral sinus thrombosis obstruction. Then the treatment is a surgery plus antibiotic. You can see the Krobeck test. The veins are engorging due to the obstructed lateral sinus. Here also due to the obstructed lateral sinus, you can feel the increase in pressure. Here you can see the sinus is absent here. That's the MRI can show us. Thank you for